safety and efficacy of sofosbuvir/daclazazvir in the treatment of COVID-19. I am Dr. Mustafa Yahoud, and these are my disclosures. This figure illustrates the similarity between the hepatitis C virus and the SARS-N coronavirus 2. Both are enveloped single positive stranded RNA viruses, and both share properties and use considerably similar viral genome replication cycle and mechanisms. Structural modeling studies confirm the high homology and conservation and support the concept that SARS-CoV-2 RNA-dependent RNA polymerase is much more similar to that from hepatitis C virus than the one from negative sense RNA viruses such as influenza and Ebola. Thus, it was anticipated that the important targets for therapy for nCoV-2 as a successful example in hepatitis C virus should include the RNA-dependent RNA polymerase and the replication complex. And this figure illustrates the similarity between the life cycle of hepatitis C virus and that of the nCoV-2, where the life cycle of nCoV-2 start from virus entry by the binding of the spike protein, protein S, to the host cell receptor, the angiotensin converting enzyme 2 receptor, and then uncoating and translation in the cytoplasm to the polypeptides acted upon by the proteases like the chymotrypsin-like protease to release the active enzyme RNA-dependent RNA polymerase, which completes the replication and the life cycle. Thus, sofosbuvir, daclazazvir, rilibazvir, ravidazvir are examples of already available direct-acting antiviral drugs that act through inhibition of target viral enzymes, including the RNA-dependent RNA polymerase of hepatitis C virus, by competing with the natural ribonucleotides. Thus, by the same mechanism, such drugs might be able to also inhibit the nCoV-2 RNA-dependent RNA polymerase, which is the non-structural protein 12, and both the non-structural protein 7 and 8, which are considered cofactors for the viral replication. As this figure illustrates the binding of the sofosbuvir molecule to the RNA-dependent RNA polymerase of nCoV-2, the study by Elfiki et al., and this study by Mondal et al. Shows clearly that sofosbuvir have very high binding affinity to the non-structural protein 12, which is the RNA-dependent RNA polymerase, and to the non-structural protein 7 and 8. This is another study by Cynthia et al. Shows clearly that daclazazvir has high binding affinity to the RNA-dependent RNA polymerase model by Autodoc Vina docking study, and this is the binding sites. Another study by Saadawi et al. Shows that ravidazvir, which is one of the direct-acting antiviral drugs, and daclazazvir and hesperidine has the highest binding affinity to the neuropilin 1, which is one of the SARS coronavirus 2 receptors. In vitro studies showed that sofosbuvir and daclazazvir inhibited SARS coronavirus 2 replication in type 2 pneumocytes cell line, CALU3, and prevented virus-induced neuronal apoptosis and the release of cytokine storm-related inflammatory mediators by monocytes. This did not show up in the studies in viral cells, which are cell line from the monkey kidney, as it was shown that the prodrug sofosbuvir has to be activated inside the cells which happen in the pneumocytes and in hematoma cells more efficiently than the cells from the kidney monkey, which are the vero cells. Daclatazvir also targeted SARS coronavirus 2 chymotrypsin-like protease enzyme, and thus other secondary RNA structures in the SARS coronavirus 2 genomes are also inhibited. Sofosbuvir terminated RNA was shown to display substantial resistance to excision by SARS-CoV-2 exonuclease-based proofreader. And this is very important study published in Nature. Here is reference number 10. An important study by Sacramento et al. Showing the predicted daclatazvir plasma concentration for multiple 60 mg and 330 mg doses. This line illustrates the effective concentration 50, and both doses are above, while as we see the higher dose is far higher than the effective concentration 90. All these data strengthen the theory that sofosbuvir daclatazvir may be attractive candidates to repurpose. The study design and the setting. This is a parallel to arm randomized open-label active controlled clinical study conducted in an inpatient setting in isolation hospital in Cairo. The inclusion criteria, including subjects or their representatives, sign the informed consent form. Subjects are aged between 18 and 75 years of age. Laboratory confirmed COVID-19 by PCR assay. Symptomatic COVID-19 with clinical severity at baseline from mild to moderate or severe. Mild was defined as mild clinical symptoms with no picture of pneumonia in CT scan. Moderate was defined as fever and respiratory symptoms plus pneumonia visible in CT scan. Severe but not critical, meeting any of the following criteria. Respiratory distress, respiratory rate 30 times per minute or above. Finger oxygen saturation 93% or below in rest state. PaO2 over the FiO2 between 400 mm mercury and 200 mm mercury in order to ascertain that the case is not needing mechanical ventilation or ICU admission. Exclusion criteria: pneumonia due to other etiology, critically severe COVID-19 cases requiring invasive ventilation at screening, patients who have severe concomitant illness that affects survival, pregnant or lactating females, hypersensitivity or contraindication to any of the drugs used in the study, patients with cirrhosis or abnormal liver enzymes with more than 3 times the upper limit of normal, renal dysfunction with estimated glomerular filtration rate below 30 milliliter per minute per 1.73 meter square. Patients were randomized into 2 arms. Arm number 1, which was the experimental arm, contains 44 patients who received the standard of care therapy according to the Ministry of Health in Egypt, together with a daily dose of 1 sofosbuvir 400 mg tablet combined with 1 daclatazvir 60 mg tablet. Both are generics by Pharco from day 1 through day 10. Arm number 2 is the control arm, comprised 45 patients who received only the standard of care therapy according to the Egyptian Ministry of Health protocol. And this included at that time hydroxychloroquine, azithromycin, vitamin C, zinc supplement, acetaminophen, and cough mixtures as needed, with treatment may be escalated according to the case progress with anticoagulants, parenteral antibiotics, oxygen therapy, escalation, up to ventilation whenever the case is deteriorated in the world. The primary endpoint, proportion of clinical recovery, composite within 21 days, composite of sustained more than 24 hours duration, normalization of fever below 37.2, respiratory rate normalization 24 per minute or below, oxygen saturation 94% or above on room air, and more than 2 points improvement in ordinal scale by WHO. Number 2, time to clinical recovery. Also composite endpoint from initiation of the study treatment until resolution of symptoms sustained for at least 24 hours with time frame 21 days. Number 3, mean change in clinical status using the ordinal scale by WHO from day 3 through day 21. This ordinal scale consists of 8 categories. Number 1, death. Number 2, hospitalized on invasive ventilation or ECMO. Number 2, hospitalized on non-invasive ventilation or high flow rate nasal oxygen. Number 4, hospitalized with oxygen supplement. 5, hospitalized not requiring oxygen but need medical care. Number 6, hospitalized not requiring supplemental oxygen or ongoing medical care. Number 7, not hospitalized with limitation on activities and or requiring home oxygen. Number 8, not hospitalized with normal activity. The secondary endpoints were time to or proportion of virus negativity by PCR of nasal or pharyngeal swab sustained for at least 48 hours at the time frame 21 days, proportion of patients who needed escalation to mechanical ventilation and or died during hospital stay at 21 days, proportion of participants with treatment emergent serious adverse events leading to study drug discontinuation. Statistical plan. Group sample size of 44 in group 1 and 44 in group 2 achieve 81% power to detect a difference between the group proportions of 0.24. This test statistic used is Z-test for proportion with bootstrapping. The significance level of the test was targeted at 0.05. A Kaplan-Meier curve was used to report the probability of progression over time to clinical recovery, and this was compared between groups using a Cox proportional hazard model with adjustment for baseline disease severity indicators. Results. Between June and September 2020, 89 patients had been included in the study and all were randomized and received their assigned medications. 44 patients were treated with sofosbuvir daclitazepam add-on to the standard of care, labeled as experimental group, and 45 were given the standard of care therapy alone, the control group. Baseline characteristics were balanced between groups as illustrated in this table. The proportion of cumulative clinical recovery in the experimental group at day 21 was numerically greater than the control group, 91% in the experimental group versus 77.8% in the control group, with confidence interval between 0.97 to 1.4, which was not statistically significant. But when we conducted a hazard ratio analysis by Cox regression model, the time to clinical recovery adjusted for baseline severity estimated by the Cox regression was statistically significant with hazard ratio 1.59, with confidence interval between 1.01 to 2.5. And this illustrates the separation between the curves, with the experimental group showing higher probability of 1.59, meaning that at any time point during the study, the experimental group have 1.6 times greater probability for clinical recovery than the control group. The experiment showed trends to greater numerical improvement in all studied clinical efficacy endpoints, including the 8-point ordinal scale score, the severity of lung lesions score by CT, and the case fatality rate, which was less than half, 4.5% in the experimental group versus 11.1% in the control group. All these effects, though, did not reach statistical significance at the study sample size, but being all concordant with the significant hazard ratio, they supported the study concept. Here is the 8-point ordinal scale, which is concordant higher numerical mean scores in the experimental group than the control group, with adjustment for baseline severity indicators, but this did not reach statistical significance in the intention to treat analysis. And this shows the experimental group showing tendency to better improvement in lung lesions with more steep reduction in the mean severity score numerically, though the difference was not statistically significant at the study sample size, but also it is concordant with all the efficacy markers in this study, which support the concept of the study. The incidence of sustained viral negativity confirmed at day 91 end of follow-up showed no statistically significant difference between the group in intention to treat analysis by two-sided exact test with bootstrapping. Two patients in experimental group versus 5 in the control group suffered severe deterioration necessitating admission to intensive care unit and invasive mechanical ventilation, and all died in the ICU. No serious adverse events reported, only comparable mild non-serious events in both groups. Discussion. The highly variable natural course of COVID-19 with a considerable proportion of spontaneous recovery and low unpredictable incidence of fatality could make the results of observational studies to evaluate treatment difficult to interpret. Even in large-sized randomized controlled studies, it was practically difficult to detect a statistically significant reduction in mortality beyond the standard of care. This may be due to the low fatality rate at the background fatality rate in both groups and the small effect size. The 3 smaller studies from Iran have been recently published, and they also showed efficacy and safety of supraverbal with or without ribavirin in the treatment of COVID-19. In conclusion, although our sample size was not large enough to have power to detect tiny effect size, yet the hazard ratio adjusted for baseline severity by Cox regression was statistically significant, 1.6. This signifies that at any time point during the study, the clinical recovery in the experimental group has about 1.6 times greater probability than the control group. This, together with the concordant trend to better mean scores of the 8 points ordinal scale, greater improvement in lung lesion scores, and lower case fatality rate in the experimental group, which was below half of the control group, though did not reach statistical significance but could add support to the potential benefit of tofosbuvir daclizumab in the treatment of COVID-19. Thank you very much.